Is this the beginning of arthritis, or is it an overgrowth? Why does it even occur? Is it hereditary?
Yeah, I think that it's not really fully understood right now. But one of the thoughts is that maybe a development problem in the hip as a child was growing caused there to be a little bit deformity, or maybe it's just something that's happened with time, that people just have developed these spurs and bumps, but that's really not well understood yet.
Right. Okay. So I guess the obvious thing is it's predictive. We talked a little bit about that, whether or not we can prevent these things. But when you see it, they're having pain.
Correct.
And you need to do something about it, because from what you're telling me, it would deteriorate into a more difficult situation later on anyway.
That is correct.
Okay. So there's a surgical, you can actually correct this surgically.
Well, right. But the first thing I would do, if somebody came to me and they had femoral acetabular impingement syndrome, the first thing that I would do before surgery would be to try a steroid injection in the hip. Because sometimes the person's having transient pain. You know, they may have had this anatomy for years and years and years.
Sure.
It all of a sudden starts to hurt, and then they present to me. I give them a cortisone. I make the diagnosis. I give them a cortisone injection, and the problem resolves. And they actually do fairly well with this. But occasionally, even with that type of thing, they continue to have pain, and then the next step would be to do a surgery on it. So the surgery is usually an arthroscopic surgery, but it can also be done open, and in fact, it's still being done open at many centers. We have a picture here of the setup. This shows a person who is actually positioned for an arthroscopic surgery on their hip. And you see we have the person laying on their side, and we actually have to put traction on the hip. We have to pull traction to separate the ball from the socket. So it's a much more involved operation than a standard arthroscopy. In addition, we use a fluoroscopy unit, which is a moving X-ray to help guide us to make sure that we're in the right place. And then we have a picture here of a person who actually has just a cam lesion. And if you look at this, you'll see on the very edge of that ball, there's a bump that's protruding out. So that bump is the culprit. And as that person moves their hip back and forth, the bump catches on the edge of the acetabulum, and that's what causes the pain.
Yeah, and I think you do have an animation of how you actually you're actually grinding away at these bony protuberance, maintaining the structure of and function of the hip.
Correct. So here we have, this is an animation that just shows what is done. And first you see, we will, if the person has a pincer lesion, we'll grind away at the acetabulum to remove the offending structure there. And this is just showing the burr. All right. And now, if the person has a cam lesion, then we'll grind away at the bump on the femur. And this shows that bump being ground away. All right, and then at the end, if you look here, you see now the hip is moving properly. There's no more pinching. On top of that, we have, this is actually stock footage. This isn't me, but this is stock footage of the actual procedure. This is done by a surgeon who does it slightly differently. I have the person on the side, but in this case, the surgeon has the person laying flat on the back. And you'll see that there are a couple of metal tubes that are sticking into the joint. And we use a fiber optic scope and some surgical instruments, and can actually grind away at those structures. All right, so that shows the actual surgery.
Really? And well, tell me a little bit about these are. Can this be done as an inpatient or outpatient? Where do you do this? Do you remember?
Yeah, this could be done as an outpatient.
Yeah,
in fact,
like
it usually is.
Back pretty functional pretty quickly.
Yeah, I mean, one of the advantages of doing it arthroscopically is that it could be done as an outpatient. If it's done open, it's a very big operation. The hip actually has to be completely dislocated.
Yeah.
Whereas with doing it arthroscopically, you're subluxing, meaning you're partially dislocating the ball, and it's not quite as traumatic.
Right. I mean, the alternative is to full hip replacement, I imagine.
Well, you know, sometimes these cases just get past simple removal of the bump, and you know, these are joint preservation operations. You're trying to catch them before the person's had complete loss of their cartilage. once the cartilage is gone, it's gone. It's very hard to regenerate.
Right.
And there are some techniques that could be done, but in the long run, that person probably is going to go on to have a hip replacement.
Yeah, I'll just interject at this point in time. I think people are aware of, certainly in knees, that there are some artificial lubricants that have been injected and had some relief. Is there any value of that in the hip?
First of all, it's not FDA approved for the hip. So if you do it in the hip, you're using it off-label. It really has not been proven to work as well in other joints as it has in the knee. It's very successful for the knee, but not so much the other joints.
You would think it would, but for some reason it doesn't. The mechanics of it must be different. The post-op course, these people, they go home, and what is the next step? How do we return them to function?
Right. So, the hip is a very, very deep joint, and if you think about a knee or a shoulder, those are very easy. They're very close to the surface of the skin. So when we work in those joints, we just make small punctures in the capsule. But the hip is deep, so to get in there, we actually have to cut the capsule open, the joint capsule, the structure that holds the joint together. And because of that, we can't let somebody just start walk around on the joint right away. We usually have to protect them for a while the capsule grows over and heals itself. So usually the person will go home and they'll be on crutches for maybe 4 to 6 weeks. And they get a lot of scarring around that capsule, so then they need some therapy. Whereas with a knee, very often you don't need to have physical therapy. With hip arthroscopy, you're going to need therapy.
Yeah.
The recovery is much longer than other joint arthroscopic surgeries.
Because I know with the replacement, they get you up pretty much walking on that thing right away.
Correct.
To get you functionally working again, but this is a little more involved.
This is a little different because potentially you could dislocate the hip if they start to walk on it too soon.
Makes sense. We're going to take a break. We'll come back and now talk about the more definitive surgeries for hip replacements.
Okay.
And we'll be right back after this message.
When it comes to your personal finances, do you feel the ENB difference?
I feel it as soon as I walk through the door. It's just friendlier.
They know my name, and I know theirs.
I'm not just an account, I'm a person.
I feel like they understand what I need, like checking without minimums or fees.
They care about my community because it's their community too.
I feel like they share my values.
I feel I can trust them, not like those giant banks.
ENB is part of where I live.
ENB, you'll feel the difference.
Effort is the kind of place where the individual is more important, and I think that gives the patients and the family the sense that you're working together to get people out of the hospital quicker. We have a wonderful, wonderful pulmonary rehab program designed for people who are short of breath, who need, just like cardiac rehab, to help improve their activities of daily living. The medicines that are out there, we can help people live longer, we can help people live better, more quality care. It's absolutely incredible to see what can be done.
And welcome back to Healthwatch. We've been talking to Dr. Tom Renz about painful hip, and we've kind of gone through a couple of not well-recognized issues. I think what we're going to be talking about now, the arthritic hip, the potential replacements that you do pretty commonly. And I guess one of the questions I asked about at the break was the bilaterality of even the impingement syndrome you talked about. Kind of makes sense if you have it on one side, will you have it on another?
Frequently. Sometimes the one side is more symptomatic than the other, but very often if a person has it on one side, they're going to have something on the other side, yes.
Would you recommend that they do the other side just empirically, or you really wait for symptoms?
As a purist, you'd say, yeah, just get it done before there's a problem, but it's really hard to, in my mind, justify doing a major surgery on a joint where somebody does not have pain. Potentially they could have more pain afterwards, and I really wouldn't want to do that.
But I'm interested in your comments when you talk about joint preservation as a kind of a new thought process, because we're all, we're so enamored now with the replacements, but we don't think about the potential for doing something prior to.
I think that if in the future we could really prove that this is the cause of arthritis, then there might be some type of surgical justification. I don't know that we've gotten to the point where we can definitively say that this is going to cause arthritis.
Okay. Well, that's a good segue to kind of talking about the arthritic hip that we're seeing in the elderly population, but I guess in others as well. And I think I can think of patients with rheumatoid arthritis, for example, who tend to have kind of joint problems as a part of their pathology. Do you find this to be a value in that population?
Well, in rheumatoid arthritis, the value of doing arthroscopy would be to just cut away the tissues in the joint. But, really, I think that we're talking about two different things. And when I talked about, what I was talking about with this femoral acetabular impingement syndrome, it's basically a mechanical problem. Whereas with rheumatoid arthritis, it's more of a disease of the soft tissues, which then affects the joint surface.
Yeah, makes sense.
So, you know, in that population, it's just trying to manage the arthritis as long as you can, and then doing the definitive operation, which would be a hip replacement.
Right, when necessary.
Correct.
Let's talk about the arthritic hip. Can be a long-standing problem. You see them at various degrees. When do you, looking at that, I guess, radiographically and symptomatically, decide that, yeah, there's nothing more that we can do for you short of a hip surgery?
Right, that's a good question. So anyway, the average age of a hip replacement patient in the United States is about 67 years old. And what we've found is that hip replacement is actually one of the fastest growing surgeries that there is. And it's really at both ends of the spectrum. It's the older patient that we're doing it more commonly in, but we're also doing it a lot more commonly in the younger patient. And we think that maybe this type of problem, femoral acetabular impingement syndrome, and other problems like this, is why younger people are getting arthritis, or we're recognizing that they have arthritis at a younger age. And also, you know, there's been kind of a shift in the thought processes of patients, is that they really don't want to accept that they have a painful, stiff hip, and they don't want to live with it at a young age. They actually push more to have joint replacements at earlier than we used to. There's a term for that, and we call it boomeritis. And really the thought is that baby boomers are just not willing to step out of life and sit on the sidelines. They want to stay active, and they can't accept their hip the way it is or their joint the way it is, and that's why we've been moving ahead. The other thing is that our technologies are improving, and we think that we're doing hip and knee replacements better than we have in the past. So we're willing to offer them to a wider age group.
Yeah, one of the questions I could ask you is that in having been in medicine prior to this and seeing it evolve, one of the questions always was when you do it, how long is it going to last? Because in fact, I don't think two things. I guess, like you said, the technology is better, the materials you're using are better. Right. But it used to say, well, you know, maybe 10 years, and then you're going to have it replaced. Well, if you're 60 years old, you're going to live to be 80. That means you could have go through a couple, and that was a rate limiting step. So when you get back to the mechanical structure itself is better than what it was in the past.
Well, you know, what happens is that if let's say you're 80 years old and you have your hip replaced, well, if you live to 110, you're not going to worn that hip out. But it could last 30 years because you're just not going to be that active. But if you're 40 years old and you have your hip replaced and you have no other reason to have pain, then that hip replacement's not going to last as long. It's going to wear out a lot faster just because you're more active. Yeah. So it's really not just a matter of the materials that the hips are made out of, but also who you're putting them in. You put it in someone who's